Okay, dokes. Right. Well, I am pretty much blown away with the number of people that have logged in. So there's a huge amount of pressure to actually produce something decent. The only saving grace is that nobody's had a drive to go anywhere and you're sitting in your gardens or you've got a glass of wine, hopefully. So that'll make it a wee bit easier. I'm Mark Frame. I'm one of the consultants that work up at Southampton General and in the Spire in Southampton and in the Wessex Nuffield. Got a practice now that incorporates paediatric soft tissue knee in Southampton General and in the Spire. So I thought it'd be quite a good thing to do, just to kind of go through. A lot of this stuff overlaps with adult, but there's some unique things and things that are much more prevalent in kids. So we'll start and go through some of those. This is the next one, the patellar instability. And it's one of these things that has always had a reputation in orthopedics of almost being like a black art, something that people don't really understand. People don't really want to understand. There's a patient cohort that I'm sure you guys have all have met that are generally quite challenging, tend to be young girls. They've often been kind of pushed from pillar to post and are pretty disillusioned with everything and pretty upset and angry. And it's difficult often unwinding everything that's happened to them so far. So I think it's super important to listen to them early, refer them early, because what we want to do is stop them becoming those sort of disillusioned people with chronic pain and real problems. So we'll take this example. We've got 17-year-old Lottie, and this is a bit of a less acute story. So she's fit and healthy, slipped on the stairs at home, really minor injury, felt severe pain, knee kind of gave way, unable to bend, and noticed that her knee looked funny. People often will tell you that, oh, their knee dislocated and the kneecap went all the way around the back, and all sorts of stories they'll tell you. So it's pretty dramatic when it happens, particularly the first time. It freaks people out. She kind of tried to get up, moved her knee, and suddenly it reduced itself back into position, and it clunked back in, pretty swollen and painful for a couple of weeks, but managed to return to normal day-to-day activities. It wasn't the first time that this had ever happened. So she starts telling me the story, and it goes back to when she was about 13, when she was doing PE and had a collision with somebody, and her kneecap came out the first time. And that was when she actually had to go up to hospital to get it put back in. And then after that, she's had multiple episodes of it dislocating before. So this is not new. She's now got to the point where she's literally not doing anything. She's all the sports, all the activities, everything that she wants to do, other than literally walking around, she can't do, because she's so terrified that her knee's going to give way, and she's been pretty miserable. Been seen after being sent to physio, and had lots of work done, lots of muscles worked with, get her VMO back in shape, get her quads back in shape. Every time her knee dislocates or she does anything else, she just gives up, and she's really disillusioned with everything. Interestingly, both her mum and her aunt have had problems with their kneecaps. One of them's just had a patellofemoral joint replacement, and the likelihood is that they probably had exactly the same thing, but just not been treated. Seen by an orthopedic surgeon in a fracture clinic, didn't really care, didn't really understand it, gave her a brace, sent her off to physio, didn't do anything else about it. She's just really not coping, and she's kind of gone to the GP again to see what can happen. I think the upshot of this is that there's a few folk that are really interested, and I think send it to somebody who's got a real interest. I've been doing more and more and more in the general, and it's interesting, as soon as I declared my interest in it, all of my colleagues suddenly found all these patients out of the woodwork that they wanted rid of. So I've got a busy clinic full of people, and if you've got somebody that you've got a problem with, or somebody who's got chronic instability of their kneecap, then just send me an email, send me a letter, send them up to me. Absolutely happy to see them. So it's a pretty complicated problem in most of them. It's very frequently that it's nice and straightforward. If they've had an acute injury, again, do simple things. An X-ray is really important, because when your kneecap dislocates, it doesn't do harm to your kneecap particularly. When it relocates, it hits off the edge of your trochlear groove, the lateral edge, and that's where it knocks off a big chunk of cartilage off the central portion of your patella. And if you've got a big osteochondral fragment, that's something that's an emergency. So the typical thing that we used to see in the fracture clinic are people being seen, put in a brace and sent away, I think is not right. They should have an X-ray at least, and they should probably all have an MRI scan just to make sure they haven't done themselves any harm. Even if they don't come to a recurrent dislocation, I think it's important to understand who the patients are likely to come with recurrence and who's got some kind of osteochondral fragment or some damage to their kneecap. Again, MRI scan if possible. So there's lots of different reasons for it. You tend, as you guys know as well, there's quite a high preponderance of girls that have patellar instability that are hypermobile. Baton score is kind of the way that we'd measure that, but it's not super reliable. You know, a lot of people are on the kind of grey scale. They're a bit bendier. They're clearly a bit bendier than normal. I'm not sure giving them a score really changes what I do. You know, the one that's got 20 degrees of hyperextension that can touch the floor with their hands and they're 6 foot, you know, they're clearly bendy, whether their Baton score tells you something different. Family history, again, it is kind of separating out those ones that have got a completely normal knee, that have had significant trauma. You know, the young guy playing rugby, 16's, never had a problem with his knee. Somebody's literally tackled him, smacked his kneecap out of position, and it's gone back in. That's a very different patient from the one with the family history who's hypermobile, who's got a whole bunch of different things going on inside their knee. So the congenital deformities that you have, this is stuff that people have been born with. They have a trochlear groove that's not got a trochlear groove, so they've got no bony constraint for their kneecap. They've got no place for the kneecap to actually run where it's meant to. And actually, I'll show you an MRI in a minute, but a lot of them, in the worst case, have got almost a dome. So they've got like balancing 2 ping pong balls on each other. It's amazing that they didn't always have a problem with their knee. Patella alta, so if their kneecap is high, the issue is that as they start to bend their knee, it's like a plane coming into land. It's trying to work out where the runway is when you're 20 miles away. And if the kneecap's not engaging in the trochlea, that's often really poor, then it's far more likely to dislocate laterally than somebody who's got a patella that's engaging earlier. And it's important, and it's not something necessarily that you'll need to see, but it's important that not all patella alta looks like somebody who's got a high kneecap. Sometimes it's not so much that their kneecap is high, but that they've got a very short trochlear groove. And actually, we look on the MRI scans to see how much of that cartilage overlaps between their patella and their trochlear groove, and it should be about a third. If there's no contact between the cartilage on an MRI scan with them in extension, then they've got alta. Femoral malrotation tends to come with it as well, so that their femur is actually rotated away from underneath their patella. This is all basically increasing their Q angle and increasing their rate. So it can be that the patella is sitting off laterally, but it's also be that the trochlear groove is rotated in medially so that it's nowhere near the patella. And also if they've got a valgus deformity as well, then that increases their Q angle. And it's all generally all of those things that people have in different degrees that causes the instability. So the problem in orthopedics came probably about 5 years ago, because there's all of those different things I've just described. There is something you can do to fix them. However, it was popularized with one operation, which was the medial patellofemoral ligament reconstruction. And that suddenly gave people who didn't have a solution for these patients something to do. Clearly that only addresses one issue, is that you've damaged your medial patellofemoral ligament or the structures on the medial side of your knee. It doesn't address any of the other stuff. So if all you've got is a hammer, everything looks like a nail. So if somebody comes in with a wobbly kneecap and you've only got one operation that you can do that might help, then everybody gets that operation. So you don't spend time working out what's actually wrong with them. And unsurprisingly, a lot of these patients fail. And it's a lot of these patients that end up coming along to see you because actually they need a derotation osteotomy, they need a trochleoplasty, they need a tibial tubercle osteotomy. They need everything done rather than just an MPFL. So really important to send it to somebody who has an interest. So you need the full toolbox. So tubercle osteotomies, you know, whether that's medializing them to affect the Q angle or medializing them and distalizing them. You know, the old days of a Fulkerson's osteotomy, which is anteriorizing them, is kind of out of kind of vogue. There's been plenty of studies and biomechanics shown that it doesn't change the pressure within the patellofemoral joint, so it doesn't really help. It's probably the medialization that's helped, but actually distalizing has been shown to be the thing that's probably most effective in helping instability. The MPFL is really important, and again, it's choosing what graft you use for that. So obviously their hamstrings is best because it's their own tissue. There's no risk of infection. There's no risk of anything. However, if they're, if they've got Ehlers-Danlos loss or they're very hypermobile, you're trying to go rock climbing with a bungee rope. It doesn't work. So, you've got to be very aware of that. And that's where the hypermobility is important to understand. So in those patients using allograft or using fiber tape, so just using that nylon tape, which is obviously very rigid, is an alternative for those patients that are very stretchy. Derotating their femur obviously addresses the issues with kind of mal-rotation of the femur, and closing and opening wedge osteotomies of their distal femur, again, to change the valgus deformity that they've got. And a trochleoplasty, which again is not something that an awful lot of people do, but I do, is to basically undermine the bone in the dome trochlea to give them a new trochlear groove to allow the kneecap somewhere to actually articulate in. You can derotate them and do an MPFL and do a TTO, but if you've got an MRI scan and you've got a knee that looks like that one on the right-hand side, you can see that no matter what you do with everything else, trying to have a kneecap that's going to track in that is not possible. So, it's really, really important that the right thing is done and it's done at the right time, because if you've done everything else and that's still an issue, trying to fix it now is doubly more difficult because they've already had everything else done. So the one on the left-hand side, you can see that's somebody that needed a derotation osteotomy. And you can see that the femur is not anywhere near underneath the patella. So again, you could do a ligament reconstruction, you could do all sorts you want, but the patella and the femur are in different rooms, so it's not going to work.
Sorry, Mark. Just had a question from Sarah saying, out of interest, when would you want to do surgery on these patients? Would you want them to have tried a certain amount of rehab? What would be your indication for surgery?
So I think that's where the early referral and an early MRI is really, really important, because there's lots of patients that need rehab. They've got, in the right person, absolutely needs conservative management first. These are not all people that we go in and operate straight away. However, as long as you know what you're working with first. So again, if you've got somebody whose femur's not rotated correctly, they've got a dome trochlear groove and their valgus, you're onto a losing battle trying to spend 3 months with them and working their muscles and their VMO and working everything, because you can't overcome the mechanics of their knee to that degree. However, if you've got somebody that's had multiple dislocations, but actually you look at them and they've got a good trochlear groove, their TTTG, the Q angle is relatively normal, they've got a little bit of patella alta and their quads are knackered and they've got nothing there, then you're probably going to achieve something really good with that patient. But it's about picking your winners. But I think you need to have that information first before you can decide who it is that's going to do really well with conservative management and who's going to need surgery kind of almost inevitably. So I think that's the reason for early referral and early MRI, and then we can go from there, working out who's going to do well.
Sarah also said, I see a lot of these at the moment, not a lot of them have had an MRI. Is this something I should suggest?
Yeah. Like I said, there's so many different things that are potentially not right with their knees. And that's how somebody ends up getting really disappointed, is that if they work really, really hard and if they're really motivated and do all the physio and it doesn't achieve anything and you keep dislocating, then it's just telling them that all that hard work was pointless, when actually, the hard work is amazing, but they just need a trochlear groove, or they need, their need to be not valgus for them to actually get what they want. So absolutely, an MRI scan. I wouldn't leave anybody without an MRI scan. I'll tell a slightly scary story, and this is a little bit just to scare everybody to actually do an MRI. There was a lady up in Aberdeen who was referred to us when I was up there. And she'd been seen by her GP, knee pain, pretty not, she kind of thought back through some vague injury that might have been a twist. She had 3 months worth of physio, wasn't really getting better, saw the GP, she had a steroid injection in her knee, didn't really get any better, eventually got sent up to us in orthopedics. She was seen and we organised an MRI scan of her knee, and she had a distalfemoral sarcoma. So it's not just about identifying the stuff that's relevant to this. You know, if somebody who's young, who's got persistent knee pain that's not getting better, they've got something going on, you know, for the sake of an x-ray, even, you know, you're not even asking for an MRI scan. Every GP could organise an x-ray. Just makes you feel that little bit more comfortable that you maybe are dealing with the right thing, and actually what all the effort you're going to put into it's going to pay off, and that the patient doesn't have something really unusual or weird or something worrying. So I'm pretty conservative. So everybody gets an MR, everybody gets an x-ray. And I think that's how it should be in the community as well.
I've got a couple more questions. From Denise, it says, going back to meniscus and ACL, when would you choose not to operate? Always conflicting advice as to whether we refer onwards or leave to manage. I think you've probably answered that, but.
Yeah, the ACL one is all symptoms. So if somebody's got persistent instability, that they absolutely need referred. And the longer they're unstable, the longer, there's some evidence that shows that after a year, your outcomes after reconstruction are not as good as if it was done within a year. So it doesn't need to be an acute thing, but you know, the sooner you do it, probably the better. You don't want to do an ACL after 3 years of somebody being unstable. Meniscal stuff, you know, if somebody's got a significant meniscal tear and they've got symptoms, they've got mechanical symptoms, then they need referred, they need something potentially done with it. That's very, very different from the patient who's got early degenerate change and a degenerate tear on an MRI scan. That's a whole different presentation, but that's not the people we're talking about. We're talking about young, healthy, otherwise normal knees beforehand, acute injury, and then a meniscal tear. They need dealt with. I wouldn't ignore that, you know. And again, it all comes down to symptoms. You know, if somebody's got absolutely no symptoms, then it's pretty difficult to justify doing something to them. But it's very, very rare to have a significant meniscal tear and have no symptoms. But yeah.
Okay, from Kirsty, I've got a patient with recurrent dislocations. MRI appears normal and very non-compliant with exercises. I guess you don't want to see her?
Well, to be honest with you, if somebody like that and they're still persistently having instability within their patellofemoral joint, it depends who said their MRI is normal. Because if that's just been reported that says, you know, there's no meniscal tears, the ACL's fine, collateral ligaments are fine, most MRs, unless somebody's specifically saying, you know, what's their TTTG, what's the overlap between the patellofemoral joint and their trochlear groove, you know, are they alta, have they got dysplasia? A lot of this stuff won't be reported. So just because they've got an MR report that doesn't say anything negative doesn't mean that they don't have anything wrong with their knee. And it may well be that it's just not, you know, somebody's just said sore knee, MR, then the radiologist is not going to comment on all the other stuff. And, you know, that's when it's important to really understand what's going on, because the reports are useful and it's something I look at afterwards, but working out the TTTG, working out all of that stuff, I just look at it and do it myself, because actually, you know, it's so variable what you get in an MR report. So just because they've got a normal MR report doesn't mean that they don't have problems with their patellofemoral joint. So I would refer that on, yeah.
And the other one is, could you explain further about the tape you suggested for hypermobile patients?
That's for surgically. So when we're doing the operation, instead of using their hamstrings or their tendons, what we use is a piece of nylon tape. So basically it's a piece of rigid artificial material instead of using a graft. And obviously that's not affected by the fact that they have unusual collagen or they're stretchy. And the good thing is that, you know, allograft, although it's like having a blood transfusion, it's tested for everything. It's somebody else's tendon, it's fine and it works well. It's not tested for stuff that we don't know exists yet. So there's always that potential risk. And the cohort of patients that we're doing it in are young females. And, you know, it'd be absolutely catastrophic for them to have something that we don't know that exists, that they get some disease transmitted to them, and they have children, they get transmitted to them. So although the risk is infinitesimally small, it's a risk that we can completely eliminate by using this other stuff. So, you know, again, it's a completely informed choice with the patients, and we go through that with them. But you know, it's another option of something else that we can use to overcome that problem.
And that's it. Kirsty just said, may send her your way. Thank you.
That's fine. Good. So just moving back, the picture on the left was a girl we just did very recently who had about 30 degrees of internal rotation of her distal femur. So that very first picture that showed with the femur rotated round, that's this patient here. And so we did an osteotomy, rotated it underneath her patella, and then put a plate on, a bit like a fracture, and that's going to heal. And she's going to need a trochleoplasty, and she's going to need an MPFL ligament reconstruction as a second stage procedure, just to help with everything else. The one in the middle is a picture of somebody who's had a tubercle osteotomy. So she had patella alta, and we've done an osteotomy, taking a chunk of bone where the patella tendon attaches, moving that down about 1 centimetre, and then securing it with 2 screws, and that heals in. And you can see the 2 holes in the patella, and that's where the 2 ends of the hamstring graft are secured with 2 little screws, and then it comes in and is attached to the femur, and that's the MPFL. And the one on the very right, you can see a small titanium button, and if you look carefully, I don't know how good the picture is, you can see a little tunnel in the patella, and that's where that fiber tape, that tape that we were just describing, goes through, rather than a ligament, which is in the 2 holes in the one in the middle. So this is a patient. So the one on the left is the before picture. It's a bit like Blue Peter, but this is the one on the left, and you can see that it's rotated in, it's internally rotated. She's got a domed trochlea, and the patella is nowhere near. And this was her x-ray. This was her last x-ray. So the plate on the right was for the derotation osteotomy. The 2 screws in the middle we're looking down through her tibia, and that's from the tubercle osteotomy. The little button on her patella is for the medial patellofemoral ligament reconstruction using the fiber tape. And you can see she's had a trochleoplasty. So instead of a dome like she's got on the left-hand side, she's got what looks like a normal trochlear groove now. And you can imagine that that makes so much more sense for why her patella is now stable, because it's actually got somewhere to glide and move in, as well as all the other restraint that's been returned to her. So it was a long road with that girl. That was pretty hard work. That's literally everything that needed done to her knee got done. And it's really difficult in that intermediate stage, because when you do the osteotomy and basically give her a fracture that she's got to recover from, after it, she's not any better, because we've rotated her, but she's still unstable. So it's pretty demoralizing in the middle section of it, because she's trying to rehab from something that's really hard, that's really sore, but actually can't see the benefit of it until the very end. And from beginning to end for her surgery probably took us about 7 months. So that's quite a long time.
Sorry, Mark, a couple more questions.
Yeah.
What do you believe the factors to the rotation of femur, e.g. earlier years, foot, hip, biomechanics?
Say that again, repeat that one.
What do you believe are the factors to the rotation of the femur?
Femur,
yeah, e.g. earlier years, foot, hip, biomechanics.
So it's just the way that the femur is. It's the way that the femur has grown. It's the way that the femur has been, you know, with the growth plates and the way that you're designed, the way that the muscle has been pulling as you've been growing. There's nothing that you can do that's going to derotate their femur other than cutting it and twisting it and putting a metal plate on it. So, you know, if there's subtle differences, if somebody is, you know, got some very slight internal rotation, ultimately that's not somebody that we're going to be doing a huge amount with surgically. But, you know, you can't overcome a malformation of your femur with, you know, muscles or changing anything. There are some patients that have, you know, malrotated tibias and femurs and everything. And I have seen somebody who's ended up with bilateral femoral osteotomies, bilateral tibial derotation osteotomies in order to give them legs that function and do what they're meant to. But with regards to patellofemoral stuff, it's generally internal rotation of the femur in relation to the hip. And you can't overcome that with anything other than surgery if it's extreme.
Next question is, what type of plate is used for the derotation?
So that patient, we ended up using a fracture type plate. So just the same plates that we would use if somebody had a distal femoral fracture. The reason for that was actually that she had had a previous surgery and somebody had done the osteotomy just to make her not valgus, but unfortunately and not particularly helpfully, they had done that but hadn't derotated her. So they'd made her not valgus and given her a straighter leg, which was fab, but they hadn't derotated her. So we had to go back in and basically take the old plate off and put a new plate on. So we needed a much more robust plate to do that. The last one, if you look at that picture on the right hand side, you can see the locking screws and you can see a plate at the side that looks a bit funny. And that was a carbon fiber reinforced PEEK plate. So that was actually made of carbon fiber, and it's much more flexible. It's exactly the same flexibility as bone, and it just helps with the healing rather than a big stiff stainless steel plate, which is what's on the other girl. But the reason that one was on is because we needed it. But normally I would use, it's an Arthrex plate if anybody's interested, but yeah.
And Denise has asked if you see adults as well.
Yes. Yeah. The problem is that when you get adults, it's a different, you end up with a different problem. If you get them when they're kind of like 28 to 35, often they're still in the situation that they're salvageable and you can do the same procedures and you do MPFLs and TTOs and trochleoplasties on patients. The problem is the longer that you've had an unstable patellofemoral joint that's been untreated, is that the increased chance of getting arthritis. And we see people kind of late 30s, early 40s who come with a story of a dislocating patellofemoral joint, really unstable. You do an MRI scan, they've got all of those same problems and you desperately need to do like a trochleoplasty, etc. But actually they've got no articular cartilage in their trochlear groove and they've just got bone rubbing on bone. And that's incredibly difficult to deal with because you can't do a trochleoplasty on somebody like that. You're not going to get rid of their pain. It's a very different ball game. Still do often the same procedures, but the expectations and the outcomes from that are very different. And that's why it's so unbelievably important to get to these people when they're kind of 14, 15, 16, 17, because hopefully you're going to stop them, A, having a life of misery of not doing anything and being deconditioned. And secondly, so that they don't end up with a partial knee replacement at 45 with osteoarthritis that they can't live with. So yeah, no, we do see adults, we do the same things, but it's slightly different.
Yeah, that's it for the time being for the question.
Okie dokie. So just finally, everybody can run away and have a glass of wine in the sunshine before it disappears. The anterior knee patient is often kind of an overlap into the patellar instability one. So you'll often get people that have got some instability and pain. And one of the questions I always ask in clinic, I'm like, if you can only get rid of one of these things, if I can give you a stable knee, but I can't get rid of your pain, or I can get rid of your pain, but you've got a bit of an unstable knee, which would you prefer? And you will often get people that it's just pain, and you know they've got a bit of instability. They've maybe had one time that it's dislocated, it's never done it again, but they're struggling with pain. And the really difficult thing is that they often have a lot of the same problems that folk that have instability have, but they're much subtler, and actually it makes it much more difficult. So they don't have that domed trochlea like we've seen on the MRI before, but they've just got a slightly flat trochlea, combined with the fact that they're a bit valgus, but not that bad. And so taking that step to then take that patient, and you're not going to do a trochleoplasty, you know, are you going to do an osteotomy? Probably not. That's not going to serve them very well because it's all very small changes. The other problem with these patients is on the MRI scan, you'll start to see chondromalacia. You see damage to the patellar articular surface, and that's what's driving their pain. And often, no matter what we do surgically, it's unlikely that we're going to get rid of all of their pain. And it's a lot of it's chatting and speaking to them, giving them a realistic endpoint as to where they're going to go. You know, you're not necessarily going to be able to cure them. You're not going to get rid of all of their pain. You can't make that cartilage come back where it's damaged. All you can do is try and kind of subtly improve things for them. We do some surgical things on some patients, so offloading their lateral facet of their patella. So if somebody's got maltracking and they're overloading the lateral facet of their patella, and that's giving them pain, or they've got chondromalacia where they're wearing away, it's basically early osteoarthritis, then doing a tubercle osteotomy, or even doing something like an MPFL along with a tubercle osteotomy to try and offload the lateral side of their knee is successful. But patients need to go in with their eyes open. I often say to them, you know, it depends how much of a problem this is, because it's difficult to get rid of all of your pain. So this isn't going to be a cure, but hopefully it will improve things. One interesting thing that we've noticed is that, again, going back to that comment where, you know, they've got an MRI scan that looks normal, got this patient telling you you've got tons of pain and they can't get over it. And they'll often see somebody and they just say, oh, you've got chronic pain, or you've got CRPS, or you're crazy, or whatever it is, and tell them to go away. We've been doing SPECT CTs, which is a combination of a bone scan and a CT scan. So it's kind of like a 3D bone scan. And why that's relevant is that it shows the active process of what's going on inside your bone with, you know, the osteoblast, the osteoclast, actually that activity going on. So if you've got trauma, you've got inflammation, you've got pressure, you've got something happening, then you've got more active processes going on inside the bone. And on a SPECT CT, you could have an MR that looks normal, and then a SPECT CT that lights up like a Christmas tree over the lateral facet of their patella, because they've got a huge amount of pressure going through it. The bone is laying down new bone because it's under pressure, but actually it's not at the stage that the cartilage started to deteriorate or anything is really obvious to see on an MR. And those patients are fantastic, because if you offload them at that stage, it gets rid of their pain, and they've not got the problem of having, you know, already got a whole bunch of damage to the articular surface already. So there is definitely a cohort of patients that get labeled as mad, but actually they're not mad. I think that comment that I put down there was that it's very rare without cause that they've got anterior knee pain, and it's just that you haven't found it, not that it doesn't exist. There are some mad patients, as you all know, but it's not actually as often as people might like to label. So that's me. I don't think I've got anything else to say. I'm sure you'll be glad that I've got nothing else to say, but there you go.
I've just had a question, Mark. Any way of offloading the lateral facet with a brace rather than a surgery? Yeah, rather than surgery.
I think there's not with a brace. I can't think of any brace, because ultimately you've got to change the way that the kneecap is tracking, and that's so set in stone with how your kneecap is attached and the angle of your knee and so many different things. I think probably the best thing that patients could do that would help with, particularly if they've got increased, or they've got chondromalacia, they've got early degenerate change in the patellofemoral joint, is weight loss. And patients don't want to hear that. But you know, your kneecap and your patellofemoral joint acts as a pulley, and it multiplies the force of your quads to make it more effective. And you know, it's about 7 times your body weight is multiplied through your patellofemoral joint. And if you've got your patella that's tracking slightly on the lateral facet, and you've got somebody who weighs like 100 kilograms, you know, you're talking a huge amount of force that's going through that worn out cartilage. And so I don't think there's any brace that's necessarily going to help you. I think physio and making sure that the rest of your body's working normally and your muscles are working normally certainly may be of benefit. But ultimately, you know, halving your BMI is probably going to be the thing that makes the biggest difference to their patellofemoral joints. You know, I think in the Spire, they had I've seen in the Perform, they've got the kind of anti-gravity treadmill. And I would be surprised if you could take anybody with any knee pain at all and put it on there and take, you know, a quarter of their body weight off, that they wouldn't feel absolutely amazing. So if patients actually did that in reality, it would make a massive difference. But I think that's probably the most effective thing you can do, but incredibly difficult to get people to do.
Sarah has said, thank you so much, that was really helpful. Sorry, I may have missed it at the start. Do you work in the NHS, and how can I refer to you? I'm based in Portsmouth.
Yeah, so we do tertiary referrals. So either directly or request that the GP does a referral. would be absolutely fine. And just into the general. So I'm in Southampton General. Sorry, I didn't say that at the beginning. The issue is that we're going to, as you guys are aware, I'm not sure if everybody's even started working again. The scenario with COVID is insane with regards to our elective stuff. We've only barely started to get going with anything. And if you get a new patient appointment allocated in Southampton General, you get a clinic appointment for June 2021. So that's not surgery, that's not anything. So a routine appointment, you get to see us in 2021. So there's going to be an awful lot of unhappy people. And I think this is why it's really important to make sure that the diagnosis is right early. And that's why having kind of like my email or some other means of contacting somebody is vital, because, you know, somebody sitting on a list for a year could be pretty catastrophic. And, you know, even the processes of trying to escalate it, they kind of go up to some management office somewhere, they go into patient services and disappear into the ether. You know, if you send me an email, I'll reply to your email, and it comes more effective from us if we're trying to expedite somebody than the GP writing a letter or even somebody's MP or something. So please don't hesitate to just send an email.
Can you put your email up again, please, Mark? They've asked.
Yeah, the last, there we go. There you go.
And if anyone else needs it and doesn't have it, I can send it as well. There are no more questions yet, but if anyone has any.
How many are still here? Who's
we've got 38.
That's not too bad. That's not too bad.
Everyone just said thank you. Someone said anything to consider for acute swelling over lateral aspect of the knee.
Really just kind of, you know, the basics. I think first of all, try and work out what it is that's causing the swelling, and just make sure that you're very clear as to what it is that's causing it. I think probably one of the best things, and unfortunately it's one of these things that's not as available as it would ideally be, is, you know, devices like a cryocuff, which is the kind of, I'm sure everybody knows what that is, but it's kind of an actual circulation system of cold water around an almost like a brace type thing, are fantastic. And actually they're not as expensive as you might imagine. I kind of thought that they were going to be like 300 quid, but you can actually go on Amazon and buy a cryocuff if you wanted one yourself for under £100. You know, and probably get rid of it again if you're done with it. So I think for 100 quid, I would encourage a patient to have something like that if they've really got a problem with their knee, or something that may be recurrent or post-op. You know, I think that sort of stuff is fantastic. So you can't get past just simple pressure and ice and rest.
Yeah, there are no more questions. Just saying thank you. Really, really useful. Really informative.
Okie dokie.
Yeah.
All right. Well, thank you, Charlotte, for organising and kind of moderating, and thank you to everybody for coming. That was heaps and heaps of people, so that's fantastic. Hope it was helpful.
No, thanks very much for sorting that out for us. Everyone really enjoyed it.
Good. Lovely.
Great.
All right, Charlotte. Thank you again.
Bye.